There we go. Welcome. So that was such a welcome. You're now on the Jubilee line. Very, very big welcome to everyone that's joined us this evening for our Journey of Endometriosis expert panel events. This is our first online event, the first of many we're hoping, but me and Anna just thought it'd be a really nice opportunity, one, to kind of show the journey of endometriosis, but also for people to get to meet some of our amazing team that we get to work with and support Menstrual Health Project a lot behind the scenes, and kind of give them a chance to kind of showcase their knowledge and expertise. Just a few housekeeping bits. If everyone can keep on mute, we're going to have questions at the end that you can put in the box. Obviously no personal medical questions. We'll pick out a couple of questions because we only have 20 minutes, and they can be asked to our different experts. And we just want to ask if everyone can just please remain respectful, just because obviously it's everyone's giving their time to be here this evening. And I'll hand over to Anna to do a little introduction from your end as well.
I don't know what else to say, to be honest, follow on from that. But we wanted to put this webinar together for Endometriosis Awareness / Action Month, because I think it's really important to highlight the journey somebody goes through with endometriosis. So whether you're kind of in the thrust of suffering with endometriosis, or you're at the very beginning thinking that you may have endometriosis, I think this webinar will really help you along your way and help support you, and maybe answer a few questions that you might have. Like Gab said, there will be time for a Q&A at the end, so just pop your questions in the box and we'll keep monitoring it. But we hope it's helpful and you can take away something from today. And yeah, I'll stop talking now and I will pass you over to our first speaker, who's Ailsa.
Good evening, everyone. Just making sure you can hear me all right. Fabulous. Someone give me a thumbs up would be great.
Oh,
amazing. Cool. So do you want me to introduce this, Gabs?
I'm just gonna pop this up just so people can see, just content warning, that we will be talking about fertility, pregnancy, food, nutrition, and suicidal ideation. So just in case if it gets too much at all, then please feel free to go off the webinar and come back in at a later time if it's better for yourself. Just look after yourself during this webinar. But from now, it's over to you, Ailsa.
Okay, fabulous. So I'm really, really excited to be here tonight. My name is Ailsa Ormerod. I'm a registered nurse from fabulous Australia. I've just moved over here and I'm very, very excited to live and explore the UK. A little bit of a background about me. I am a women's health and sexual health nurse. I have done further training in women's and sexual health, and I also have a lived experience of endometriosis, adenomyosis, and chronic pelvic pain. I'm incredibly passionate about everyone being really, really informed on endometriosis, and particularly those of you who are maybe thinking that you could have endometriosis, recognizing those signs and symptoms of endometriosis, where you can go to seek further help and how you can manage your pain and get further help for your pain as well. So if we head on to the next slide, we'll do a little bit of an introduction into what endometriosis is. So it's a systemic whole body condition, inflammatory condition, where cells or tissue similar to what lines the uterus is actually found outside of the uterus in places where it's not supposed to be. It has been found on every organ in the body, and it can lead to lots of inflammation and lots of debilitating symptoms in people. It's a condition that affects around 1 in 10 women and those assigned female at birth in the UK. And if we head to the next slide, we'll actually have a look at the symptoms of endometriosis. And I think this is a really, really important slide for us all just to have a look at. And what I want to say at the start is this isn't a checklist. You don't actually have to experience all of these symptoms to have endometriosis. In my career, I've looked after people who've had 2, 3, 4, all of these symptoms as well. So if we look through a couple of these ones, just want to point out a few to you. So we've got pain, before, during, or after periods, pain throughout the cycle, pain that starts to interfere with your daily activities. We can have nausea, vomiting. We can have IBS symptoms like bloating, diarrhea. We can have pain when we do a wee, pain when we do a poo. We can experience symptoms of chronic fatigue. And so it can really start to affect our whole life. But what I did want to just reiterate is that this isn't a checklist. And it's important to recognize, okay, I could have some of these symptoms, I could have all of them, or I could only have a few and still have endometriosis. So if we head to the next slide, this is a question that I get asked all the time as well. So why do we actually experience pain at period time? So what happens in the body at period time is there are these natural chemicals that get released from the uterus called prostaglandins. And what they do to our body is they cause the uterine wall to squeeze and cramp and contract. Sorry, I use my hands a lot when I talk. To squeeze and cramp and contract to help the blood to shed. And that's actually why we get pain at period time. And if we head to the next slide, we'll have a look at, I guess, what's a normal period. Now, what's also really important to know is that normal is going to be different for everyone, okay? This is, going to vary from person to person. Consider it like a normal period to only last from about 3 to 7 days with that light to moderate blood flow, not kind of soaking through tampons or pads quite regularly. Changing those products maybe about every 3 to 4 hours. Some people have no pain at period times, only a little bit of pain that can be really easily managed by themselves, whether that's through heat or medication. And this pain should not interfere with the things that you love to do, you need to do, or you want to do. So if we head to a next slide, we'll look at what is an abnormal period. And that's just what I just said there. So we need to start thinking about how our periods are affecting our daily life. We also need to look at how much we are bleeding at period time. I just said that, soaking through one pad or one tampon every hour, that's too much blood. And that can actually start to affect us in other ways, looking at our levels of iron in our body and our fatigue as well. And pain that doesn't settle with simple self-management strategies. And it's really important that we need to start thinking about maybe reaching out and speaking to a doctor or a nurse that we feel really comfortable with. And if we head to the next slide, when to speak to a doctor. Again, I have just said that. So if your period doesn't settle and you start to get severe pain or bleeding, you start to get pain in other areas. We know people can get shooting pain down their legs and their back. And if you are concerned with any of those symptoms of endometriosis, and again, like I've been saying the whole evening so far, if your periods are stopping you doing what you love to do, what you need to do, and what you want to do, carrying on with your normal daily tasks, that's a really, really good time to start thinking about seeking help. And I'm sure our fabulous team is going to talk to you all about what that looks like in the next step.
Thank you so much, Ailsa. So now we're going to pass you over to our primary care specialist, who's Dr. Angela Sharma and Dr. Rebeccah Tomlinson.
Next slide. Yeah.
So I'm Dr. Rebeccah Tomlinson. I'm a GP in South Wales. I'm a member of the BMS and Faculty of Sexual and Reproductive Health, and I'm the Welsh Medical Advisory Board member.
And I'm Dr. Angela Sharma. I'm a GP in London. I'm a British Menopause Society menopause specialist and also clinical sexologist. I'm on a menstrual advisory board. I'm one of their trustees and I'm on their medical advisory board as well. And I'm also the co-founder of Spice to Pair Health. Next slide, please. So I'm just going to start off with a few facts about endometriosis, which are quite important to understand and to then understand what we can do about it in a general practice setting. So endometriosis is the second most commonest gynecological condition after fibroids in the UK, and it affects approximately 10% of women. And it's commonly diagnosed between the ages of 18 to 29. So that's quite a wide gap and this is because there's a significant diagnostic delay in diagnosing endometriosis, and it's approximately 8 years in the UK, 8 years and 10 months in the UK. So the All Parliamentary Group did a survey of 10,000 patients with endometriosis and asked them a few questions. And we found that like 53% have already visited A&E with their symptoms, and 43% had actually visited doctors in hospitals over 5 times already. And 58% had visited their GP more than 10 times. And when asked, 90% would have liked to have psychological support, but weren't offered this. So we can see that it's quite a significant condition. It's quite common. It affects quite a lot of women, and there's this delay in getting diagnosed. So Rebeccah and I are going to talk about what you can do to make sure that your visit to the GP is useful. And I'll pass over to Rebeccah now to do the next slides.
Thank you. So we know as GPs that, one of the main things that patients say to us is actually getting hold of a GP, the troubles of accessing a GP in the first place, even to discuss the problems. So, firstly, I want to apologise on behalf of primary care for that, but we're just going to run through a number of the reasons why you might have an issue. So firstly, our telephone systems. There is not a perfect telephone system, unfortunately. You all are aware of the 8 a.m. phone lines turnover from the out of hours, and it's like you're in a rugby scrum to the finishing line to get into the queue, and then you hear this automated message telling you you're 31st in the queue, and you feel that you've got no hope of getting an appointment. It is really difficult, and from that point of view, in the telephone system, it is an issue. We are aware of it, but just to say, obviously, Monday mornings are going to be really chaotic. So it can be that if you can wait, then looking at one of the kind of middle days. Wednesday generally is a quieter day in general practice overall, but picking a different day to try and run the gauntlet of the phone system. We also know there's a change of access to primary care, partially due to the COVID pandemic, and a lot of GPs have moved to telephone triage. So this means that you're not offered a face-to-face appointment straight away, but you might be put through to a member of the team to have a chat through your problems first. Now, this is, tricky for some people because it's ideal to have a face-to-face conversation with the clinician, but it's just understanding that this is the way that's actually managing the high demand of patients through the service, and so it's at that point really just stress your desire to actually want to be seen face-to-face, and most of the time the GP will be able to put you in with the right GP at the right time. We know that receptionists are sometimes a barrier for patients getting access to our service. They are the gatekeepers, but actually things are being changed within the services where actually our receptionists are becoming our social prescribers and signposters. So we do know that people do not want to give their medical information out to the receptionist, but sometimes they will be able to be the people that know best, and be able to kind of point you in the right direction. I always say to people I'm talking to, the receptionist is the person who's going to know which doctor you want to see. So sometimes just going along to your practice and asking your receptionist, which doctor do I need to see about women's health? And you may have to wait a while to see that doctor, but at least you know that you'll be speaking to somebody who's going to be understanding of your issues and be able to give you probably a better consultation about your health. And in the same vein, GPs, we all have differing specialities. So in my clinic, I'm the women's health GP, but we have a musculoskeletal doctor. We have one that specialises in diabetes. So coming to see me with your women's health is great. But if you see any of the other doctors with your women's health, you'll probably end up in my clinic anyway, because they will redirect you. But that's what a good practice will do. If you're not seeing the right GP, they should be confident enough to redirect you to the GP who's going to be able to support you best. Next slide, please. And what I think both myself and Angela would kind of agree on is preparation is key. If you go and you are prepared for your appointment, then it can make the appointment flow a lot better. You can download symptom trackers to list your symptoms. So that puts your symptoms in black and white. And that can also show if your symptoms are cyclical or fit a certain pattern. Look at your family history, ask relatives what are your close female family members already diagnosed with. That can give us a good understanding of what potentially we might be looking at as a clinician. Tell the doctor if your symptoms impact you psychologically and socially. This is really important. You know, a lot of times it's difficult to talk about the hard stuff. And we do pick up a lot of cues from patients when we see them. But if you're doing a telephone conversation, you know, we're not going to be able to see if you're visibly upset or struggling. And so we do need to know, how is your symptoms impacting you? And also document all the things you've tried already, and don't be afraid to say to the GP if they're offering you something you've already tried, say, look, I've tried this, can you check my records? It didn't work for me, could we try something different? There's the fantastic menstrual health toolkits, and they are amazing to get the conversation started with your GP. Bring it along with you, and it's also information for the GP if they're not, you know, specialised in that. So just all of that will just lead to a better quality consultation, because the discussions will be led by you and your GP can better understand your concerns. And also really important, if you feel you're going to need a double appointment, then request it, and that will give you more time. Thank you, Angela.
Thanks, Rebeccah. So what about on the day when you get to your consultation? So some tips is obviously just to try and take some notes if you can. It's just because the doctor's going to be talking about lots of different things, and sometimes a lot of patients just go in, and if they get upset about something, then everything just switches off and you don't remember what someone said. So you might miss some things. So it's quite a good idea to write things down. They might be giving you other websites to go and look for information. They might be talking about investigations they might be doing, or medications, and just advising you about other things in the consultation. If you're really going to struggle on the day and you think that you're, you know, going to find it difficult, or you might find it hard to talk about some of your symptoms, or if you just need someone else to listen as well and be there, then just take a friend or a family member, someone you trust, someone you're happy to talk about your medical conditions in front of, and ask them to take the notes, or ask them to ask the questions on your behalf, or collaborate what you're saying as well. Just to remember that when you go in there and you're talking about your focus, which is endometriosis, when you're mentioning, the GP will want to know what symptoms you have. But when someone comes to us with symptoms, and if a patient tells me that they think they've got endometriosis, that's immediately on my list of diagnoses. But as a GP, you have to remember that we have to think about all the different diagnoses as well. And so what your GP might be doing is to arrange some ultrasounds, or might do some blood tests as well, just to look for other causes as well, or rule out other things, so that the diagnosis of endometriosis can be a little bit more stronger. They may also suggest things like taking some treatment like painkillers, or more some hormonal treatments first. This is because before referrals, most secondary care would have expected us as GPs to do some of these things. So don't feel fobbed off if the GP is trying to start you on some treatment or suggest try some things. What really, really, really helps, and this is where I know, and Rebeccah knows, where things go really wrong, is that when you leave, you need to have a really clear plan of action, and also make sure you follow everything up. As a GP, you know, I get hundreds of blood results every day, and just trying to make sure that I ring everyone back and follow everything up is administratively like a nightmare for me. And so I really do rely on people and to make sure that they follow up for their blood tests. So if a doctor says, I'm going to organize blood tests, book yourself an appointment straight away, and then make sure that you follow up for the results, and make sure you talk to the doctor, or you've looked at your results on your app, and speak to someone about that. If they've organized a scan, make sure that you've had the scan. If you don't hear things, follow them up. If your GP has said that they're going to refer you, make sure that the referral's been done. Give GPs at least like a week or two just to make sure things have done. Sometimes I don't do referrals straight away and have a set time in the week where I do referrals. So just give them a bit of time, but just follow up as well. Make sure that that's been done, and just anything that they say that they're going to do, follow it up. And I absolutely love those patients who do that, because they help me keep an eye on things. So I'm going to make sure I do my bit, and they keep a check on me to make sure that I've done them. And then make sure that you maintain that. It's really nice to see the same GP as well, someone who knows you, someone who knows what's going on with you, so that you don't have to keep starting the same story each time. So that's another tip. Next slide, please. So the next thing that I'm going to talk about is referrals to secondary care. So I'm going to talk about it in terms of NHS referrals and private referrals. So because it's Rebeccah and I, it's NHS England and NHS Wales, and I will say something about NHS Scotland, but in our referral pathway for England, we use a system called ERS, Electronic Referral System, and that's the only way that we're allowed to do referrals. We're not allowed to fax things, we're not allowed to send paper referrals anymore, so everything has to be done through this one system, so all the GPs use the same system. And for our area specifically, we have a specific form for referrals, for gynecology referrals. And they will say, depending on what the symptoms are, they will ask us to do very specific tests. If we don't do these tests, they will reject the referrals. So this is why, as a GP, I will always try to think about these things early. I try to organise them in advance if I know that someone's going to need a referral. And then when I go to do the referral, you pick gynecology, and then there's all these different symptoms are listed. So it's not the different clinics that are listed, it's symptoms. So if I choose pelvic pain, then through that I will then be able to see some endometriosis specific clinics or general gynecology clinics. So you could ask your GP to refer specifically for endometriosis clinic if you're very clear, or you've already had a diagnosis, or you know that everything else has been ruled out from the tests that the GP's done. If your GP won't do that, then you'll have to go through a general gynecology clinic. You can always ask your GP to write probable endometriosis on the referral letter. Again, that focuses the gynecologist's mind about what they may be dealing with. And unfortunately, on the NHS system, we can't refer to a particular doctor, but we can request a doctor maybe in the clinic letter. That's because the clinics are all on speciality and not doctors' names, because they're constantly changing. So but we can't guarantee that you're going to see that doctor, even if they put the name in the letter. In the NHS Wales pathway, there is no generic, there's no sort of set letter, and it's just like a simple generic letter that you can write anything on there. There's no specific tests that you need to do before the referral. And what the GPs there can do is they can write for the attention of the endometriosis clinic or a specific doctor, same as in the NHS England pathway. And what's really, really important that NHS Wales, that actually the referrals can be downgraded or rejected. So we really need to put as much information as we can as GPs in there. So the more information you give to your doctor, the better it'll be. And that's why it's really important to have that double time, make sure you talk about everything and the doctor can write everything down. NHS Scotland is a little bit more tricky because obviously I don't work there, but from what I can hear is it's a very similar system as NHS England. Like, you have to have done certain tests, you have tried certain treatments before you get referred to secondary care. And then it's quite complex because there's very few, same as in Wales, very few specific endometriosis specialist clinics. And so referrals can usually get pushed through the gynecological pathway and then only get to an endometriosis clinic at a later stage, which all adds to the delay in being seen by an endometriosis specialist. If you have private insurance or if you want to self-pay, then you can go down the private route. If you're going through an insurance company, you need a letter from your GP. If you're just self-paying, I think most doctors don't mind you just turning up, but some of them may request a letter from your GP just to get the scans and tests. So sometimes some doctors like scans and blood tests to be done. If I'm a GP and I'm writing a private letter, I'll just add whatever tests that patients had done, but it's not necessary. You can absolutely specify a particular doctor that you want to see, but the only thing I would say is you just make sure that your doctor is covered by your insurance company if you're going through that way. So that takes us all the way through to secondary care, and I'll pass over to my secondary care colleagues to take over.
Amazing. Thank you so much, Angela and Rebeccah. I'm just going to do a little introduction. So we have the amazing Anthony Griffiths and Amer Raza talking about accessing specialist care. So we will hand over to them for their portion of the event.
Anthony, please take a lead. Carry on.
Thank you so much. It is unlike the rugby. I'm delighted that Wales is going before England, which is unusual. But there we are. That's grand, yeah. And the importance of accessing specialist care is really, really important. And there's lots of things you can do as healthcare providers and certainly as patients to really drive and get the service that you should have. And one of the things I wanted to mention, there is significant differences in healthcare between England, Scotland and Wales. And you've got to look back in time why there's a difference, really. And I suppose pre-NHS, we had fragmented healthcare, variety of charities and providers provided all sorts of care in different hospitals. And there was significant variance. There was very poor evidence-based. It wasn't really financially managed in any sensible way. And there was massive, huge inequality. Then nationalisation came, and with nationalisation came one of many, many things, some uniformity of healthcare as best we could do with our limited resources in UK. And then as time went on, I've done medicine, I suppose, about 25 years, and there's been significant changes in the models of health delivery, certainly in Wales and England, and there's a difference. And whereas England went for a kind of a model of trusts would almost compete for patients, and the classic line was money followed the patients. So the more complex procedures you did, that was quite good for the organisation because money came with the patients. Wales went for a slightly different model and sounded a really good idea at the start, and there's kind of pros and cons with it. And they went for a model of health boards, health providers would collaborate. And that is a really useful model. For instance, if Hospital A is specialist service in something, well, we can direct patients that way. And if Hospital B is services somewhere else. So services may not be more local, but they certainly at a higher quality, and better quality of delivery. That sounds a great model until money gets tight. And you can imagine what the next thing I'm going to say is money gets tight, health providers start squeezing services down and start refusing to collaborate. And that's kind of where we are a bit in Wales. We've got differences in quality of services, and many health providers then are refusing to accept from a neighbouring health board. And that brings problems because certainly as clinicians, we want to see all patients and we want people to have the best possible care that's equitable. So that's kind of where we are, and that's the kind of difference in Wales at the moment. But how to drive accessing services. And at a personal level, as you can see already, is presenting yourself to primary care and even secondary care with a good history, use apps, question the diagnosis, and you can do these things in a really polite way and say, dear doctor, I really do have these symptoms. I wonder, could it be endo? And this app actually supports it. Probability says I should be referred. And that's a really important way. And don't feel disheartened if you're batted back. That it's always worth pursuing that because we can really provide good and effective services. At a more general level, one of the things I find really important, for many years I've tried to change services of endometriosis in Wales, and it kind of gets batted back as a clinician, but certainly patients, groups, pressure group can make a huge difference, and they really have in Wales. And I can list a few: the endometriosis wall, the endometriosis march, the fair treatment of women in Wales, created a task and finish group and really changed our Welsh Assembly government and put endometriosis higher up on the ladder to say, well, actually, this is a major problem. We cannot tolerate 1 in 10 women rolling around in agony and having a miserable lifestyle. And actually leaving people in this scenario certainly results in high risk of suicide, employment failure, education failure, etc. But treating people early is financially wise for any country, and it's certainly the ethical thing to do. And these have made a difference. One of our big steps of allowing accessibility to endometriosis in service in Wales, Welsh Assembly Government appointed specialist endometriosis nurses for every health board. And their remit is several remits. One of them is an interface with primary care and that's almost an education, a supportive type role, which is a really useful thing. But the other thing is many of the specialist nurses take direct referrals, and they are really wonderful people, and you can email them and ask your questions. You can say, well, I've got these symptoms, but I'm having difficulty accessing care, and they can give you advice how to gain greater access to the care. So that's a real useful scenario. Tertiary referral services, pre-British Society of Gynae Endoscopy, started off as people having specialist interests and pooling services together. And the BSGE wanted a large data set to kind of audit data and create long-term publications of quality of service. And so that was a really useful thing. We've now got 3 endometriosis centres in South Wales. We often consider North and South different because there's a 4-hour difference. We're almost a different country. And that's useful. So we centralise in services. But again, we've got places in Wales that kind of fall outside the remit of these health boards. And there's, I suppose I'm providing significant advocacy for these ladies in Welsh Assembly governments that they need to be treated early. So I'd put to you is patient power has made a huge difference for many women in Wales. I got asked about 4 months ago, who's the most aspirational person you've ever met? And it is certainly endometriosis patients, because they put themselves out for the benefit of others. I'm going to stop there to be salient.
Thank you very much, Anthony. And I will just start where you just finished. That I will say these are the most inspirational people. It is not the Department of Health. It is not the doctor. It's not the NHS which can change this very difficult situation we have with endometriosis. It is rather the patient themselves. And since projects like Menstrual Health Project, Endometriosis UK, and many other organizations come forward, we have seen a sea change. The challenge we had actually in UK and actually worldwide now, from states to Australia, all the data I see, that people present with so many different symptoms from very early age. It's indeed a challenging diagnosis to be made. And because of the variation in the symptoms from bowel problem, bladder problem, period issues, and going on to fertility and other problems, it's very difficult for a GP to make a final diagnosis and say, oh, you have endometriosis. Let me send you to Dr. X and B in endometriosis unit. It is a challenging thing for them. And this is a challenge actually which then translates into this difficulty. However, now things are changing. So if we talk about UK, we in UK now have BSGE accredited centers, which does mean that now BSGE has this certified 72 centers, out of which 42 are accredited and the rest are provisional, where they are expected to have a consultant gynecologist with experience and interest in endometriosis surgery. This is a complex one, along with the colorectal surgeons, urology colleague, fertility, have a specialist nurse and a system in place where they can manage this complex patient. So when a patient goes to GP, and Rebecca actually has given a fantastic talk about in primary care, if on ultrasound scan, on examination, they see on that report, there's a bilateral endometrioma, and I can also plug in here that ultrasound scan has been a fantastic investigation, but not been utilized to its best. But now with time, we're getting better in scanning people and understanding that most of the time we can diagnose endometriosis by ultrasound scan. So if we get the standard of ultrasound scan better in our primary care, and a GP reads the report that this patient has a bilateral endometrioma, negative sliding sign, or things are stuck together, they're not mobilizing much, this gives a very good clue to a GP that this patient with those symptoms possibly has endometriosis and should be referred to hospital instead of using any local treatment. It's absolutely right to use medical treatment with either pain relief or hormonal contraception. But once given the severity of symptoms and that kind of ultrasound scan report, it's absolutely right to refer these patients to the main hospital. Now, 7-year wait is something we all hear again and again. And yes, it is a 7-year wait, simply because it is made up of so many symptoms. We have pelvic pain to bloating, severe intestinal cramps, pelvic pain during intercourse, constipation, diarrhea, bowel problem. All these situations create a very difficult situation. And then secondly, there is no single test then I do this test and this test comes back positive, negative, telling me there's a disease. Yes, there are new things coming up, but there is still a lack of a single test. Extensive differential diagnosis, preconception and taboos. Anyone, I'm sure many of the participants who will be in this webinar now will realize they spoke to someone that I have a pelvic pain, period pain. They were told that's common. It's common to have it. Or we don't want to talk about this problem because they affect so much of our work, our professional life, our school and college life when they're in this young age. Lack of resources, lack of knowledge, lack of research. I can keep on going with these things that has led to a very challenging situation with endometriosis. And that needs changing attitude at the top level, at the government level, where resources flow. And I think thanks to projects like Menstrual Health Project and people like Anna and Gabs and many others who are really voicing their concern and talking openly about it, share their story of pain, so it changes the attitudes. If I take an example of states now, the day they have changed the laws and more resources to endometriosis, when one of the senator's own daughters actually had the disease of endometriosis, and he understood the severity of the problem. And the same thing applies here, then when it comes to our individual things, how we can apply. Again, if I look at the politics of endometriosis, we have limited resources. It is not a public health priority, at least not at this stage. We have a very limited research. It's only now that we have some research coming from Scotland, coming some centers in London, but it's a very limited research. And research obviously happens when there's money. And if there is no resources behind it, research doesn't happen. Very challenging area. All parties, parliamentary group started to change things and now working to change. So that's an ongoing process. When it comes to NICE and RCOG, we still have a lot of challenges of this situation. Now, when a patient comes to us in a tertiary care, when we see them, like Anthony sees them in their hospital and we see them, the most important thing for us at that time is that patient should be the center of care. And we deal with a very difficult group of patients as well. Why difficult? They are very young patients. Subfertility is very important to them. Thirdly, the pain has absolutely made their life so difficult, right from the school age, young age, all the way to where they see us possibly when they're 27, 28. Most patients now, they have gone through the most difficult time of their life through that time. So at that time, in a tertiary center, it's very important when any doctor sees you, they have to look at everything from the symptom point of view, from the disease, and from fertility perspective. It is not a cancer where a doctor decides to just start removing things. Absolutely not. Where we as a doctor decide to be radical to remove the disease, we have to be very careful to make sure that the functionality of every single organ is also stable, which means when we're treating the ovarian endometrioma, we don't damage the ovaries. When we're treating the endometriosis from the fallopian tube, we don't take them out and damage them. Our same thing applies to bowel and bladder and uterus and adenomyosis and everything else. So the management of this has to be very careful, crafted, individualized, with the help of multidisciplinary team, that what's the right thing for that patient. And that's, again, organizations like this one, we should give information and knowledge to our patients. So when they come to a clinic in a tertiary center, they're able to verbalize it, that what they want to do and how their symptoms have been affecting their quality of life and what their priorities are as a patient. It is definitely not an easy thing to do. And I'm just adding this thing here as well. When it comes to treatment in any tertiary center, there are three basic things for us in the center. Number one, the management of endometriosis has to be holistic. So it is not about medical, it's not about operation. It has to be holistic, which I'm sure my colleagues will come and they will talk more about it. Secondly, medical treatment is the key. Now, we do not know why endometriosis, where it starts. We can talk from immunological issues to genetic to environmental to implantation. I can go through so many things, but we do not have one single answer why endometriosis starts. Because we do not have one single answer, we do not a single reason, we don't have any answer either. But medical treatment, the baseline is, if I give any hormones which can stop the estrogen, stop the periods, it will help the symptom. Keeping that argument, keeping that thing in mind, then various medical treatment are designed, from contraceptive pills to Mirena to progesterone and to Dynagest and many other treatments as well. Surgical management has to be very carefully considered, and hence in tertiary centers now, BSGE accredited center. So every patient's management is discussed with the radiology consultant, who sees the extent and the depth of the disease and talks with other colleagues in one room that how should we manage the bowel, the bladder, the ovaries, the fertility, and all those questions, and surgical treatment. Things are changing, new research is coming, and I'm sure that way things are moving right now. I really hope that in next 2 to 3 or 4 years, we possibly will have more answers than questions, but still it's a long way to go. And again, I will just say organizations like these ones are helpful for us to make this things move forward. Thank you very much. I think I'll pass the baton on.
Thank you.
Thank you so much, Tony and Amer, for that. That was amazing. I'm going to hand you over to Dr. Kirsty Harris now.
Thank you. Thanks, everyone. So yeah, my name's Dr. Kirsty Harris. I'm a clinical psychologist, and this is a bit about me. So a bit like my colleagues were just saying, I am an endometriosis patient. I was an endometriosis patient long before I became a clinical psychologist, because my symptoms started when I was 12. And I went on to become a clinical psychologist, and it was my final consultant that did my most recent surgery, who, a bit like my colleague said, it is people like yourself, women who will make the difference, and would you consider sharing your story and sharing your skills and seeing if that helps. So here I am trying to do just that. So I trained at Oxford University. To be a psychologist, you do an undergraduate degree and then you do a doctoral degree. It takes about 8 to 12 years altogether. So I did that 10 years ago, and I work in perinatal mental health. So I work predominantly with women and birthing people in the NHS. Some overlap with what I do in my day job, if you like. But for me, when I had endometriosis, when I was at the peak of some of my distress with endometriosis, there was I've put little, but I think that's generous. There wasn't any psychological support available to manage the impact of the disease. And I didn't have a diagnosis for the majority of my experience. It took about 20 years to get my confirmed diagnosis. I thought that's what it was. I've seen some people in the comments going, I kind of knew I had it. I thought that's what it was. I was the same, but I didn't have it confirmed. And what I ended up doing was sort of taking my professional training and skills I was using as a clinical psychologist in my day job and using them to try and support myself. So there's very little evidence about psychological therapy in endometriosis. What I'm drawing on here is what helped me, and what continues to help me as somebody with endo. Okay, on to the next one. So Angela mentioned this earlier, but the research shows that 90% of people wanted psychological support but were not offered it. And I think that's for several reasons. And I think it's because of the way endometriosis impacts your relationships, and it impacts all kinds of relationships. It impacts relationships with other people, and people have mentioned your romantic relationships, sexual relationships, friendships. I think it can be very hard to make friends when you keep having flare-ups and needing to cancel your plans. Your professional relationships, your career, kind of who you are in terms of how you're perceived by other people is impacts your relationship with yourself. I know a lot of people will say my life is very different because I have endometriosis to what I think it would have been had I not had endometriosis. It has I think a huge impact on your relationship with your body, and many endometriosis sufferers will also have other things that impact how they relate to their body, impacts our mental health, and I think you have an impact you have a relationship with endometriosis itself. You have a relationship with the condition and any other health conditions that come with it, and you have a relationship with your pain, and you have a relationship with what it means to live with it. I kind of, in my marriage, we described it as sort of an unwanted third wheel. It's kind of always there, impacting how you relate to one another, but you can't necessarily overcome it in the way that you would have liked. Okay. After the next one, please. So I tried to think more about distress and how to understand that, because clinical psychologists, we often focus on distress. And for me, my endometriosis experience was full of distress and times of really high distress. And I thought a lot about what drove that, what was underlying that distress, and what continues to underlie it at times. And for me, a lot of that came down to shame. And I think shame is an emotion we all experience at some point. It's there for a reason, like all emotions. None are particularly good or bad. They all have a function. We have to relate to them all. But the impact shame has on us can differ depending on our response to it. And the thing I think is very key in shame or guilt is that they carry a threat of social disconnection or rejection. So for me, having endometriosis was one where I often felt like I was different to other people, like there was something wrong with me, like I didn't fit in, that if people knew about it, that I would be judged or rejected or unloved or unwanted in some way. And I think that came from lots of things. So I thought I'd talk a little bit about external and internal shame and how they might show up in this journey. So I'll go to the next one. So external shame is where our attention is focused outside of ourselves, often on the perception others have on us, of us, which could result in us being rejected. So if we think about kind of things like period stigma, the sense that our periods are embarrassing or they're disgusting. Both of our consultant colleagues have been talking about all the range of symptoms that you might have to go and talk to somebody about, some of which you might feel embarrassed to talk about. You might not know how to bring it up or how to ask for that kind of support, depending on your own experience, what culture you're from, what the norms are where you're from. All of these things can make us feel that what we're talking about isn't okay in some way. And we may also have experiences of kind of body shame, which might be kind of form of bullying. So people might make inappropriate or hurtful comments. So one of the really common symptoms with endometriosis, which I also covered at the beginning, is bloating. I was asked lots of times if I was pregnant. I was asked if I was pregnant when I was desperately wanting to be pregnant and wasn't. I was asked about, using the lift at work. People would make comments that I didn't need to be using it because I was young, and then I would feel very embarrassed that I was using it. And all of those things can be very hurtful and make us feel more ashamed and more, I suppose, self-conscious. Okay, next one. I think over time we can sort of internalize that, that if people keep telling us that there's something wrong, either in the way that we look or the way that we are or the way that we're being perceived in terms of our physical appearance, we can start to feel quite disgusted by that. And I think also when using mobility aids, that's another thing that will come up. So, I had to, would use a wheelchair at times, and that was something that again would be commented on often by strangers, but sometimes even by people who are very close to you, sort of saying, oh, do you really need to use that or do it that way? And it again sort of activates that sense that what you're doing is somehow unacceptable or unbelievable to others. And if we move on to the next one, we'll see that then can start to get internalized, and it can become how we see ourselves. And some people have mentioned through the presentation how many times women present at GPs, how many times we present at different consultants, what it's like to try and get access to the right kind of specialist centre. And I saw a comment in the chat, I also was somewhere where there wasn't a specialist centre. So across my journey, I saw 8 different consultants because of the different symptoms, and some were gynae consultants, and some were urology consultants, and some were nephrology consultants, and because they weren't linking the symptoms together, and a lot of that was very unhelpful. So over time, as you're repeatedly told your experience is not accurate, not valid, not true, I think that is beyond words to try and articulate what that is like. And you can start to question your own reality, start to wonder if you are making it up, You start to sometimes hide that from other people because you're worried that they won't believe you. There was lots of times for myself, I didn't bother ringing the GP because I just couldn't face it. I didn't think they were going to take me seriously. And over time, I think that can start to make you believe that the problem is you, that it is your inability to cope, or that you are making a big deal out of something that perhaps you shouldn't be. And I talk a lot about shoulds in therapy. Okay, next one. So these are some of my own personal examples, and I've seen these crop up, and earlier some of the colleagues were talking about the research in this. So I was told that my periods were normal, that I had a low threshold for pain, that I was too tall. I'm 6 foot. I don't really know what relevance that had to my menstrual cycle, but it was brought up. The wrong foods, the wrong diet, not doing enough exercise, that it would get better as I got older. And I know people are going to talk about diet and exercise and so on later, but over time, I came to believe I was failing to cope. I wasn't strong enough. I wasn't as strong as other people. I was weak and I was inadequate in comparison to others. And I often would blame myself for what I was experiencing, rather than being able to access the support that is now more available. Okay, next one. And that can have a huge impact on mental health. The biggest overlap is with depression and anxiety. But it can also have an impact on couples' mental health, as both members of the couple are trying, like I was talking about, that kind of third wheel, you're both trying to navigate this. So there's, on the slides, there's some of the symptoms with anxiety, which is kind of, I call anxiety an overdrive. It's a kind of constant energy and worrying and fear. It's very, anxiety feels very busy. And very alive and alert. And if we go to the next slide, we'll see depression. And I think depression can sometimes feel slightly different. So depression can sometimes feel a bit flatter. You haven't got some of that energy and that drive. You might be more self-critical. You might be more irritable. You might also have thoughts of not wanting to be here. Quite commonly, I think in endo is just a thought of like, I can't keep doing this. Like, how long can I keep doing this for? And sometimes that again can be something that we might want some support with. Okay, on to the next one. So obviously, as our GP colleagues were highlighting earlier, these are all things to tell your GP about. And I think sometimes we can be reluctant to talk about the impact on our psychological health. If we've got that fear that we're going to be dismissed or not taken seriously, then we might not want to mention the impact it's having on our mental health because we're worried that it will again be dismissed as being to do with our mental health. But actually, this is a holistic approach. Like everybody's saying, it has to consider both the physical and the emotional health of people with endometriosis. And I think we need to be able to see them all together and see them all as true and accurate, that this is happening. And then I think you're going to be able to make the progress that we're beginning to see. So for me, my model that I like and that I use is a model called compassion focused therapy. And the idea behind this is that compassion gives us the courage and the wisdom to descend into our suffering, but in a safe way, in a way that you don't feel overwhelmed. So I think if you can do that in a way that allows you to do that with care and connection rather than self-criticism or self-destruction, then that helps you to navigate those really difficult times where all you can do is survive. That moment by moment kind of pain that comes, or challenges that come, and you're wanting to be able to just connect with some care and compassion in that moment. Okay, the next one, please. So it's two things, and social media talks a lot about kindness and being kind to yourself and self-kindness, self-care. It's a bit different to that compassion, because you can be kind to somebody without being without having the motivation to be compassionate, because it's both the sensitivity to the suffering that somebody is going through and the commitment to relieve it. So you have to both connect with their distress and want to be able to do something about it. So you could be kind, for example, you know, giving somebody your seat on the bus or something, but you might not necessarily be connecting with their distress at that moment. You're still doing something kind, but this is both. So it's a hope that you're not going to feel this way forever. And I think the work with Menstrual Health Project and so on is very much about that. It's a hope that it's not going to be this way forever. Okay, next slide. So there's some information here about compassion focused therapy. So it's not my therapy, it's written by Professor Paul Gilbert and the Compassionate Mind Foundation. And one of the reasons I like it is because it's what we call transdiagnostic. So it can be used in a whole range of different difficulties, and can think about how connecting with compassion can help us in all of those experiences. So you can sort of have a look into this if you want to. Okay, the next one, please. But what I wanted to give you was just a little kind of snippet of it that you could go away and think about, and hopefully would be helpful. So the idea is around compassion flows in 3 different directions. It flows from ourselves to other. So those of us being here today to share the information with you, that comes from a compassionate place. We're hoping to show a bit of a self to other compassion and share information that's going to be helpful and hopefully alleviate some distress for people. It also comes from other to self, and it also might come from self to self. So it's that thinking about what does that feel like. So if you were talking to a friend, for example, so that's self to other, so you were talking to them about their experience, what's that like? Do you give different advice to what you give yourself, or do you speak to a friend differently to how you speak to yourself? Is it easy for you to accept compassion from other people? So if your friend is very compassionate to you, what's that like? But also, how do you relate to yourself internally? And that is one of the first ways that you can begin to think about connecting with compassion in your own life, and in a way that I hope will be helpful. And I'll hand over to the next person.
Amazing. Thank you so much, Kirsty. I just wanted to say a massive thank you, because although you're kind of speaking from a clinical point of view, you've also got your lived experience. So we just really appreciate you sharing that with us and everyone as well. So thank you so much. And we're going to hand over to the lovely Olivia Wall, who is our registered dietitian on our medical advisory board. So take it away, Olivia.
Hello, my name's Olivia. Thank you very much for introducing me. So just a little bit about me. I'm based in North Devon in the UK. I studied human nutrition and dietetics as my undergrad, and I'm partway through my master's in paediatric dietetics. But women's health at the moment is kind of my main focus, and I've been absolutely loving working with the Menstrual Health Project to kind of advocate for women's health and nutrition. So I do have a clinical background and have worked in the NHS and do some work in the NHS now, and also do some freelance or like private work that mostly specialises in fertility and women's health. So we can go to the next slide. Thank you. So of course, I am a firm believer that there is a few fundamental pillars of health, and that we should get the basics right before we try anything crazy or before we add too much complication on top. So my kind of 3 fundamentals of health is nutrition, and I guess these are in no particular order, but nutrition is really important to me. My second one is movement, and it doesn't have to be that you're a marathon runner, it doesn't have to be that you do a 5K every weekend, it doesn't have to be XYZ thing, just movement of some kind that you enjoy in your body. And the third thing is connection. And I think the Menstrual Health Project and like platforms like this are really brilliant for reaching out to other people, and that kind of social support, knowing that you're not alone and there's other people to rely on too. Next slide. Cool. So then I guess nutrition is definitely my my main interest. It is my job. So in terms of thinking about our day-to-day needs, the super important bits, I'd say number one, carbohydrates. It tends to be the thing that goes by the wayside the quickest when we start dieting or when we try and make changes to our health. But they are really important, and yes, your body can function without them, but I'd say generally I'd be skeptical that it can function as well as it can with them. It's going to change depending on where you are in your menstrual cycle and what your hormones are doing, but having some carbohydrates, ideally every day, is a really good way to start. Secondly, having plenty of protein in your diet is really important to keep all your muscles functioning and repairing any damaged tissue. And so we're not just thinking about growing our biceps or our glutes or our quads or that kind of thing. We're talking about all the different types of muscle in the body. So the smooth muscle that helps your digestion, your heart is a really big muscle, and even the muscles that move your eyes around so you know where to look. Protein is really important in all of those tissues. And then thirdly, important to make sure we're having some fats as well. So this again is one of the things that often goes by the wayside if we start thinking about changing our diet, but is really important. I would advocate for using healthy fats as much as we can, so things like olive oil and oily fish, but I'm definitely not against the odd cupcake or fish and chips at the weekend. Food to me, and I think hopefully to everyone, is so much more than just fuel. It's so much about how you spend your time and interaction with people, a celebration, socializing. And I would never want you to miss out on a food or an event or something because you heard one time a dietitian or a nutritionist or someone said, you probably shouldn't have that. So totally have Prosecco on your graduation day, have Ben and Jerry's if you go through a breakup, and cook a Christmas dinner with your family, because those things are all just as important as the nutrients themselves. Next slide. Cool. So in terms of endometriosis, which is obviously why most of us are here, the recommendations and what we know about nutrition is unfortunately lacking. So despite what you see on social media, despite how many reels of anti-inflammatory foods and this thing for endometriosis and that thing for PCOS, the evidence undeniably is lacking. So there's currently no nutritional recommendations from NICE, which is the National Institute of Care Excellence, regarding endometriosis. Hopefully that will be changing soon, and some of my colleagues are doing brilliant work in the nutrition and endometriosis space, but there's currently no guidelines to recommend any supplements or sell you anything, so just to keep that in mind. And despite our lack of evidence, in several surveys, we have found that about 50% of women with endometriosis have tried a dietary change to try and combat their symptoms. It's not a stupid thing to do, but it's impressive given that we have such little evidence as to what is actually useful. So the next slide, please. Lovely. So in terms of endometriosis and nutrition, I keep trying to make that one word. What do we actually know? So people with endometriosis are 2 to 3 times more likely to have an IBS diagnosis. And you might be sat there thinking, yep, that's me. But why is that? So it is a common misdiagnosis, especially with the long period to being diagnosed with endometriosis. One of the easier things to diagnose, or one of the things that they like to rule out first, is IBS. And as we've mentioned before, it will be similar again in terms of parallel symptoms. So some pain, some bloating, maybe at different times of the month, depending on your cycle as well. So there are parallel symptoms. So it is understandable that it's commonly diagnosed along the same lines. And the third reason that we can see this increase in IBS diagnosis is because of stress. So if you are stressed day to day, if you're in pain, if you're struggling to do day-to-day life and work or study or whatever it is that likelihood is your endometriosis might be affecting, then that can also affect your digestion, and that will exacerbate symptoms of IBS. Next one. Amazing. So what's the first step in terms of nutrition and IBS, nutrition and endometriosis? Generally, we'd say opt for a Mediterranean style diet. So we're focused on providing lots of omega-3s, some fiber, lots of our B vitamins, plenty of healthy fats and antioxidants. There's a little diagram here on the slides, but you'll be able to find a wealth of resources about the Mediterranean diet online. Generally, we're opting for things like plenty of whole grains, plenty of fruits and vegetables, keeping to a couple of portions of oily fish per week, a couple of portions of eggs or lean meat, and a more sparing intake of red meat or highly processed foods. Again, definitely go for the cupcake or go for the pudding that you enjoy, but maybe not all the time. So when women experience IBS alongside endometriosis, they also might benefit from more tailored support. So we know that if we have IBS, some of these foods might be particular irritants to our symptoms. And so it's worth making sure that we know what we can tolerate well, what we can't tolerate so well, and not overdoing restrictions that are undue. Cool. Next slide, please. Amazing. So in terms of endometriosis, nutrition and fertility, there are some things to consider. So about 50% of women or those who are assigned female at birth with endometriosis will suffer with some kind of subfertility. It's not to say that you'll never have children, but it's just may take longer for some people than others. And that can be due to a multitude of factors. It might be because of your endometrial tissue, or it might be because you have painful sex and you don't want to have sex as often as someone without endometriosis would. But there's a few things to think about in terms of our nutrition. I'd say the first of which is our vitamin D status. So especially in the UK, as adults, we should all be having a vitamin D supplement in the winter, ideally, because we just can't get enough from the sun. So that is normally how we synthesize our vitamin D, is from the sun, but with the few daylight hours that we have, it's just not enough. Especially if we are of darker skin tone or we're unable to get out and about so much, it's especially important to supplement. The second thing to be really aware of supplementing is folic acid. This helps prevent neural tube defects in our offspring. So it's really important, ideally, to have that as a supplement for at least 3 months prior to conception, and especially through the first trimester as well. For some women with endometriosis, if they might have struggled to get pregnant for a little while, we do consider as well using coenzyme Q10. It's not something that is a necessity for absolutely everyone, but especially in the population of like 30, 35 and onwards, it can be useful and some of the outcomes are quite good. Cool. Sorry, next slide. Cool. So endometriosis and menopause is another kind of life stage to consider. And similar to how we all have different periods or we all experience womanhood differently throughout our lives, menopause is likely to be different for a lot of us as well. So it might be because it's an age that we naturally reach menopause, or it might be that it's been medically induced. And a lot of the time symptoms are similar, but they will vary in duration and might vary in severity. So some things to be really aware of is making sure we have plenty of protein whilst we are experiencing menopause. During menopause, we have a lot of muscle wasting, and it's really hard to maintain our muscle mass. So having plenty of protein to make sure we're replenishing what we do use is really important. The second thing is calcium to be really aware of as well. And calcium and vitamin D work really well together. So if you are being aware of one, it's really useful to be on top of the other as well. And this will help maintain our bone density alongside some regular activity. We want to kind of keep ourselves active so we can keep our bones nice and strong. Another thing to be aware of is isoflavones. So you might have heard this potentially from your doctor, especially if you are in medically induced menopause, is to be aware of soy and soy products. So these products do have some proteins that can mimic some of our estrogen hormones. So for some women naturally, although likely very few, having plenty of soy products can limit or can help minimize our menopause symptoms. But that said, it is for quite few women, and if you're in medically induced menopause, it might be something that your doctor or consultant tells you to be watchful of. Next slide, please. Brilliant. And then just quickly to touch on endometriosis and bowel surgery, it can be a really tricky area, and you might have to go against a lot of the dietary recommendations that you have heard before. So if your endometriosis has reached your bowels, especially if you have surgery to have a stoma, or maybe down the line have a stoma reversal, the recommendations are likely to be completely different. In which case, the advice may be to have a low fiber, or what we'd call like a surgically low residue diet. And that just makes sure that we're not putting too much pressure on our bowels, especially if we've had surgery and we're waiting for things to heal. It's important to be really on top of our hydration. But for some of us, especially if we have our Stanley Cup and we're used to drinking a lot of water, it might be different, and we might have to reduce slightly just to make sure that our stoma output and bowel function is nice and regular. If this is the case, we can look and aim for gradual improvement of our diet over time, but it's definitely not going to be a 0 to 100 on surgery versus day 1 after surgery day. Amazing. So just quickly to finish, I wanted to touch on a goal setting. It can be really tricky with ourselves as adults to look at changing our nutrition or our lifestyle habits and then keep accountable to it. So that's probably one of the main things that I find comes up in clinic, is trying to keep accountable to our changes and what we want to achieve. So it might sound a bit primary school, but setting some SMART goals can be really helpful. So instead of just eating healthier or eating more anti-inflammatory foods, you want to make it really specific. So thinking about, are you trying to eat more fruit and vegetables? If so, how many portions? How many days a week? What about your hydration status? How much are you trying to drink? How many days a week? Are you going to carry on with that goal even when you're on your period? Are you going to carry on with that goal even when you're on holiday? And just setting yourself really realistic time bounds as well for those goals. And if you reach a goal, amazing. Give yourself a pat on the back, book yourself a massage, upgrade a kitchen appliance, give yourself maybe a non-nutrition focused reward, because it's worth having yourself as a priority, and it's worth congratulating yourself when you do meet those goals. And of course, there's so many more things to think about. So in terms of fertility, nutrition, and women's health nutrition, I get so many questions about ovarian reserve and testosterone and our gut microbiome and all these supplements that I've seen on Instagram, and recipes, and how might this affect me when I'm pregnant, that kind of thing. So there's always someone to ask questions to, and I think it's just reassuring to know that you can always reach out for help. If you have any questions, there is plenty of people available, and do never be worried to ask for help. Yeah.
Amazing. Thank you so much, Olivia. That was so helpful.
Yeah.
I hope it's been really helpful for everybody, and we've had quite a few questions to ask our medical advisory board. So currently we have 4 questions from the chat and our Instagram. So if anybody has got a last minute question that they want to pop in, please put it in the chat now and we'll do our best to answer it. So me and Gabs are just going to alternate asking the questions, and then whoever from the medical advisory board may want to kind of jump in and answer. So the first question is, do you all still get nervous going to the doctor even though you have a diagnosis? After 20 years of medical gaslighting, I find it hard to trust them, but I'm now lucky to have a really supportive GP and practice nurses. So probably coming from that, from my own stance of suffering, and I'm sure Gabs will, is to believe that there is a doctor out there that will listen to you, and I'm sure our doctors on the panel will reassure you and give you some tips on how to speak to them, and also to advocate for yourself. I'll pass you over to
I was going to jump in on that as well. I was just going to say, I think I still get really nervous, and I think me and Anna always talk about this, and I'm sure most of our board as well have lived experience that. I could even go and see my endometriosis specialist, who I've seen literally for almost 10 years, who's the nicest person ever, never gaslights me, and I still get nervous going. And I think it is difficult if you've had a bad experience or a string of them, that kind of gets embedded. And I think as a society, we focus on the bad things over the good things, in a sense, where I feel like we're more inclined, if we've had bad experiences, to kind of, they stay in our brain and we complain about them. In the sense, we will make a complaint, whereas if something good happens, we don't tend to give a compliment. Yeah, I definitely still get nervous. I think me and Anna both do, and I'm sure a lot of people do. So I think that's totally normal. And I think the whole purpose kind of us having a medical advisory board and having medical professionals on the board is to bridge that gap, where I think it's been prehistorically, people kind of feel like it's the patient versus the medical professional. So that's a really important aspect for us, to kind of make it not as scary for people. Would you say, Anna?
I can just say, as a GP, I get nervous seeing people that I've not seen before as well. I don't know how they like to be spoken to. I don't know whether anything I say is going to upset them, and and they're going to throw all this stuff at me, and I'll have to, like, I don't know what's coming at me. And that's with every single patient. You don't know sometimes what's coming at you. But what really, really helps is, for me, I love seeing the patients that I already know. I love that relationship building with them, and then they don't have to start from the beginning, and you don't have to start from the beginning, and it just makes it easy to be able to follow the journey. So if you find a GP and you don't get along with them, try another one. Keep trying till you find there'll be one that you will get along with, or one that will understand you. And I think there is a GP for everybody out there, that understands the way that they like to be spoken to. Or so I think hang in there and keep trying, and if you will find somebody, I'm sure, that'll give you that time.
And if I can just add as well, like, if you were thinking about that internal and external brain that we've sort of touched on today, it is expected that when you've had a difficult experience, like Gab said, our brain will look for that, it will focus on that. And the reason it does that is because it's trying to protect us, because our brain works on better safe than sorry. So if it's going to another appointment and we've had a bad appointment in the past, or we've had 10 years of bad appointments or 20 years of bad appointments, then our brain goes off like a fire alarm and it says, watch out, what if this appointment is the same? So it's trying to warn us. And sometimes it's helpful just to remind our brain, a bit like everybody's doing, and saying, thanks for reminding me, but actually I know this GP really well. I know this experience isn't going to be the same. I feel more able to advocate for myself now. And you can talk yourself through that experience like in a therapist or in a compassionate self-talk kind of way, but it will show up because it's trying to be helpful. And I think it is important to remember that these tricky loops that we get caught in are intended to be helpful, and we can also unhook ourselves from those with all the things that people are talking about.
That's great. Thank you, Kirsty. I think that's really helpful, kind of from the mental health element. I feel like I'm going to take that away now when I go to appointments as well. So thank you. That's really, really helpful. The next question we've had is, how can adolescents identify endometriosis? Is it true that the first 3 years of pain and irregular periods is normal?
I think I can take this question. First of all, first 3 years of it's not normal. No, endometriosis can start at any age. It can be diagnosed at any age. The challenge comes, which every speaker has said today, that it's not an easy diagnosis to be made, especially when you're young and you come to a clinic asking about your pelvic pain, pain with passing urine and bowel symptoms as well. It's a difficult one. The endometriosis can start from very early age, from 13 and 14, even though it becomes more predominant after 20s at that time. So yeah.
Sorry, I couldn't unmute myself. Thank you so much for answering that question. I think that's one big thing that we get asked when we go into schools is whether it's normal for teenagers to be suffering. And like you said, it's definitely not normal. So the third question we've had, how do we all deal with a lack of post-surgical treatment options other than pain management? I feel like once I had surgery, everyone assumed I was cured, especially after my third when I had a hysterectomy.
Mm-hmm. Is Anthony here, or I will just carry on?
Indeed. Yeah, it's a real challenge, isn't it? It's one of those fantastic myths that sadly exist as well, and it's such a pity. And it's again back to that standard holistic care. And it's from the outset to saying, really, what is the evidence of surgical intervention? What are the anticipated outputs, really? And then devising a holistic care package of preoperative, intraoperative, and postoperative care, really. And all that's really important stuff. But it is challenging. It really is to change people's mindsets. And as you know, we've got some really good evidence-based practice of endometriosis care, but frequently ladies with endometriosis care are surrounded in either a lot of ignorance and ignored to a degree, but also some evidence-based stuff as well, really. And there's some cultural reasons why that's true as well, sadly. So it is challenging. And I think you're back to patient support groups and empowering people and speaking as a louder voice then as a group to saying, well, no, actually, this is a chronic condition. Here's the various treatment modalities, but it, currently, sadly, is a chronic condition.
Yep, I will absolutely second that it is a chronic condition. Surgery is not a cure for endometriosis. It simply helps to excise the adhesive disease that we find where structures are stuck together. But that's just one part of it. Second part, it could be turned into neuropathic pain when the nerves get involved as well. So surgery is done. It helps us to excise all the visible disease. But the second thing will come again with physiotherapy, with psychotherapy, with dietitian, with exercise, with all those things have to then come together to help this person to learn to live with the life. And actually, I say to my patients in my clinic as well, that we have to learn how the life will be once you have been diagnosed with endometriosis. It's not one surgery, two surgery, even at hysterectomy or removal of ovaries is a cure as well. Because sometimes, in spite of all these things, patient will still have some degree of pelvic pain. So we have to just learn how to cope with the pain and how to get the right things out of this situation.
Thank you, Amer and Tony. That was really, really helpful. The next question that we've had is there a risk to fertility for those who have had surgery for endometriosis?
Maybe I can start from here. So there are very important distinctions to be made when it comes to endometriosis and fertility. We know that 20 to 30% of people will have impact on their fertility just because they have endometriosis. Endometriosis can block the fallopian tube. Endometriosis can create that environment within the pelvis, which is not conducive to fertilization. So that's number one. So endometriosis itself having an impact on fertility in 20% of the people. Second thing, when we operate on these people, the surgeons have to be extremely careful operating. And if we go back 2-3 years ago, if someone has endometrioma, means endometriosis in the ovary, we used to do a stripping technique. So you go and grab the cyst and you completely strip it off, because we know by stripping technique, you're treating it properly. Cyst will not come back. It's a better treatment. But with time, we have learned now that when we did that stripping technique and removed the cyst, we had caused an impact on the AMH level, which I'm sure many of you have heard about. It's one of the fertility blood tests, and also the ovarian follicles and ovarian reserves. So now when it comes to endometrioma cyst in the ovary, we are very reluctant to do cystectomy. And the most common thing is that unless someone's family is complete and they don't want to have children, then it's absolutely right thing to do cystectomy, because it will reduce the risk of recurrence. But if someone is young, they want to have children, they want to have family, then draining the cyst and treating it with possibly simple diathermy and washing and cleaning the ovary will be enough. But if there is endometriosis in the pelvis, not in the ovary, in the pelvis, no, that does not have any impact on fertility. it is absolutely right then to excise the disease. It is the ovarian endometriosis which has the significant impact. And as I said to you, that we know and we have already changed the management of endometriosis in women who want to have children.
Amazing. Thank you so much. So the next question is, I think probably for you, Olivia. It says, I have long-term low residue diet due to endometriosis on the bowel and having surgery for bowel endometriosis. Any tips for getting the nutrients in without being able to have fibre?
Yeah, it is a really hard one. It can be such a big change as well. If we're used to having a relatively healthy or high fiber diet, I think the change is a really hard one to deal with. I think knowing what you can and can't tolerate yourself is really useful. So if you were to try a food and it doesn't agree with you, then don't have it for a little while. Let yourself have a period of recovery before you potentially try something else or before you try adding other things in. The way you cook food won't necessarily change the fiber content of it. So knowing which kind of low fiber foods you can have that are higher nutrients is really useful. So often when we're missing fruit and vegetables, it's important to know that we can have some of them a lot of the time. A lot of us will manage quite well with like things like tinned peaches or apricots or that kind of thing, or well mashed potato, swede, carrot, all those kinds of veg, as long as we're not having skins and pips and those kinds of things. In terms of other nutrients that we often miss out on, so a lot of our whole grains, which we miss out on, contain a lot of B vitamins, but it's reassuring to know that a lot of our low fiber cereals are fortified with those vitamins and minerals that we miss out on. So even if you can't have Weetabix, but you can have Rice Krispies, or you can have Honey Hoops or whatever it is, they do tend to be pretty well fortified. So if you have a lot of bread or cereal or that kind of thing that you can tolerate, opting for the best fortified options that you can.
Amazing. Thank you, Olivia. That was really helpful for me as well. I've been taking some notes as you've been chatting because that's a big thing for me, low fiber. So thank you from a personal stance. The next question, I've just read it and I'm going to laugh only because the end of it is funny, not the actual question. Do you feel patients could benefit from various medical teams working together like Endo Avengers, which I love? From a patient point of view, I definitely think so. I think all patients, that's kind of the dream. It's not always a reality. But yeah, I think from a patient perspective, yes, please. But I'll let some of the professionals answer from their point of view.
I think from a professional perspective, definitely yes. It would be nice to work more closely with more endometriosis specialists.
As a GP, I would love to have like an MDT, multidisciplinary team meeting to talk through the patients and what we can do, who to refer, where to refer, what other things they can do. Yeah, brilliant.
From a nursing perspective as well, and just like Angela said, we need a multidisciplinary team to manage people with endometriosis because there's so many conditions that can overlap and so many different teams that are involved in the care of that patient. So 100% yes.
Yeah, I mean, just add here as well that, I mean, I cannot even think of working without a team. I simply cannot function. Patients are so complex and so difficult that a fertility specialist, colorectal, urology, dietary, psychiatry, it all comes together. Otherwise, there's no way one single person, no matter how good they are, can answer all the questions and can satisfy. So no, team is absolutely the key and the linchpin of all the endometriosis care.
I think you're absolutely right. Is the best medicine is not working in the silo, is working with your colleagues. And it's actually the most enjoyable bit of all medicine. I just came back from an endometriosis boot camp with about 30 endosurgeons, but the highlight was listening to a variety of people in imaging, in primary care, in medicine, in genetics, and all this really fascinating stuff. And it becomes new ideas, create new ideas. And that is patient-centered care every time. It's brilliant.
Sorry, I'm really slow on the mute button today. So last question that we've got is, why is endometriosis not classed as a disability? I'm going to throw that out there.
I think somebody sort of answered it in the chat, but if we're talking about the definition in accordance with the Equality Act, then there is sort of not a list of conditions that fall under the Equality Act. It is substantial and long term. So the way a Equality Act would define it in the UK is that substantial, so it's would take you longer than normal to complete a daily task, for example, getting dressed. And long term means that it's persisted for 12 months or more. So if you have endometriosis and it meets those two things, that it's substantial and it's long term, then under the Equality Act you can, it is protected as a disability. I think one of the struggles can come with advocating for yourself around that, with people understanding it. So even when you start to say, for example, you'd be covered under, say, like access to work in the UK. If you say to your employer, I have endometriosis, some employers will know what that means and they will know the impact of that, but some won't. So you may have to explain why that has an impact on you and why that might fall under Equality Act and under disability. I hope that makes sense.
Yeah, that makes complete sense.
Amazing.
Because I think probably yourself as well, Gabs, and anyone on here with endometriosis probably identifies as having a disability, with it stopping you from doing what you want to be doing, and it being so long term and often grueling for a lot of patients. But like you said, there's not that one list, is there, where it's listed on there. So it's more about the circumstance of the patient. But yeah, thank you so much for answering all the questions. And
I actually had just not necessarily a specific question for our lovely panel, but more kind of just as a throw out there to anyone that kind of has any input. And it's something that kind of last question has made me think about. And I've spoken to Anna about this and my husband as well. But what I never understand is, so if you have a life insurance policy, when I took out life insurance and I declared I had endometriosis, my premium went up. But society, or it's not deemed as a life-threatening condition. So it's very conflicting, and I think it's difficult, the disparities with certain things like that. When you're talking about, also we're saying that endometriosis should be a disability. I think it's just all of these kind of inconsistencies, isn't it, Anna? These little things that we talk about, where endometriosis is recognized in such high regard and really serious in certain scenarios, but in other scenarios it's not, but then it kind of works against you. And especially things like life insurance. I don't know if anyone else has had a similar scenario where life insurance don't recognize, well, they recognize it as a threat to your life, that your premium goes up, but then it's not recognized as a life-threatening condition kind of outside of that.
Yeah, it's the same with travel insurance, isn't it? Like, my travel insurance tripled in price when things started getting really bad. And I probably, to just kind of go a bit further on your question, Gabs, for probably Anthony and Amer who can answer this, but why in the UK especially are we not taking it seriously as a condition? Why obviously I think from the work we do, I think personally I know why, but it would be really nice just to hear like your opinion on why you think we don't prioritize it as a country to kind of support people in a better way.
I think if endometriosis would have been a man's disease, I can tell you it will be one of the most important things we will ever hear. We will hear every day news. There will be new research, hundreds of millions would have been spent, and so far you will have a cure as well. That's my honest answer, what I think.
You said it, Amer. You said it.
I can give a political answer as well. Sadly, there has been absolutely no investment, if we look at the investment gone into other cancers and problems as well. If endometriosis is a disease and we put all the women together, if endometriosis, it will become an 8th largest country in the world. It is so many people suffering with it, but sadly,
that's mental.
But well done to all the work which MHP and everybody else is doing it. This is changing. We can already see it now. Patient don't come and tell me now, my GP has sent me. Yeah, I'm sure GP has sent me as well. But they come and tell me, I spoke to my friend. I Googled it. I found this way. And I thought it could be endometriosis. That's why I'm coming to see you. I can see every single day in clinic now. Attitudes are changing. Knowledge is changing. Knowledge is a power. And seems like power is shifting now in the patient's hand. I will just say one thing as well. The patients who are listening as well. When you go to tertiary care center or secondary care centers to speak to consultant, be brave, be bold. Write everything you are suffering through, but be ready for everything. If you are rejected, if you're pushed back, it's not the case. Ask them, question them. They may challenge you, but then they will think again that there is something they can do more to help you. And that's I think, what the big message will be. Thank you.
Thank you, Amer. I feel really empowered after that. Love that.
Tony, were you going to say something?
Yeah, there was this, we got some real dreadful things in medicine. We got paternalistic medicine that still exists even in medicine. We got a cultural barrier to talk about endometriosis. And one day there'll be a day where you can walk down the street and say to people as opposed to how's the weather, you can say, how's your periods today? And we've got these cultural barriers. We can't talk about pain. We can't talk about pelvic thing, anything that is gender difference. We've got barriers to talk about, and it's a cultural thing in the UK. Are we different to the rest of Europe? I think we are, to be honest. And that's an issue. And you're right in terms of, we know we got massive gender differences in survivability and outcomes in terms of operations, and that's not because of biological reasons. And we even sadly, if you look at COVID recovery across different health boards, COVID recovery, if you're female, your waiting list is longer than your male. So there's still gender inequality in healthcare, which honestly astounds me every time I look at it, but it's factually accurate. And these are some of the barriers why endometriosis is often pushed to one of the bottom and seen as not a serious condition, which it is.
Amazing. Thank you so much, Tony and Amer, and everyone, all of our amazing panel and speakers, for doing such a great job tonight. We've had loads of great feedback from people, and just a huge thank you, really, I think, from me and Anna to everyone as well for joining, but also for our whole team. When they say it takes an army, it really does take an army. And I think me and Anna are so incredibly lucky that we get such an amazing team, our trustees and our volunteers as well, who just support us in everything. They follow us, and me and Anna sometimes have some crazy ideas, mad ideas, things we want to throw together in a short space of time, or things we want to do that some people might say to us will be impossible, that'd be really difficult. And kind of the unwavered support we get from all of our team, and all the support from everyone through social media who supports the charity. We're really, really lucky that we get to do this. So yeah, just a huge thank you. But I'll let Anna say a little spiel as well.
We talk for Britain, so I'm not going.
I know, you've got to break it up. I talk for England, Anna talks for Wales, and then jointly we talk for everyone in the UK.
And I'm sure Anthony and Rebecca will know the Welsh can talk if they keep going. But I just want to say a huge thank you. And again, one to the panel of our amazing medical advisory board. We couldn't do what we do without you guys, and our trustees who are on the call as well. But also for everyone who's listened in today. And I just hope it's been incredibly helpful. Any feedback regards to the webinar, we really do welcome. So please email it to us. And if there's anything else you'd like to see from a different stance and for different conditions as well, please pop that in your email. But just a huge, huge thank you. And like we said, it is recorded, so hopefully we can get this put up so it's accessible for other people. But yeah, thank you so much, and
thank you, everybody.
Take care.
I'm going to stop recording now.